All right, we're going to go ahead and get started as it's 12:10. I want to thank Brittany for kicking us off with some oldies in the way of music. So thank you, Brittany, for doing that. I want to welcome everyone to a special session of the GME College. For those that have participated in the GME College in the past, this will be kind of familiar to you, but for those that are new with us today, the GME College is really meant to think about the curricular topics that bridge across many of our residency, fellowship, and other health professional programs. We think about topics ranging from quality improvement, patient safety, diversity, equity, and inclusion, resident and fellows as teachers. And today we're going to be talking about approaches to pain management, which is a topic that is critical for all health professional trainees and all health professionals in general. We have a special presentation today led by a trio of amazing educators and clinicians. I'm really looking forward to this collective conversation on principles of multimodal inpatient pain management. We have today Dr. Matthias Behrends from the Department of Anesthesia, Dr. Amber Borucki from the Department of Anesthesia, and Dr. Kat Lau from the Department of Medicine leading our conversation. I'll have each of them introduce themselves a little bit more as they each share their thoughts on this critical topic of multimodal inpatient pain management. With that, I would love for everyone to give the three of them a virtual round of applause and sort of welcome them to GME College.
Thank you so much, Dr. Hun, for that wonderful introduction. I also want to ensure that my colleagues have an opportunity to introduce themselves and what their clinical as well as leadership roles are in our health system. So Matthias, I'll allow you to introduce yourself first. Matthias, you're on mute.
I gotta change that. Hello, my name is Matthias Behrends. I'm at UCSF at the Department of Anesthesia and Palliative Care since 2004, and I'm currently serving as the Director of the Acute Pain Service and the Medical Director for Inpatient Pain Services.
And Amber, I'll allow you to introduce yourself next.
Hello, can you guys hear me?
Yes.
Okay, perfect. My name's Amber Borucki. I'm sorry, I'm in the hospital, so I've got my mask on. I am a pediatric anesthesiologist, and I also have training in pediatric pain management, and I am the director of the Pediatric Anesthesia Pain Services.
And I'm Kat Lau. I'm an adult hospitalist and am the director for a value improvement program at UCSF called Caring Wisely. I also have been helping to lead a pain orders subgroup committee, which is a subgroup committee of the pain committee at UCSF for the past few years. So our roadmap for this workshop today, we've covered our intros. We're doing the roadmap now. I'll go over the objectives shortly. I'll kick things off by announcing what changes will be made soon to the inpatient pain medication ordering in APEX for both the adult and both children's hospitals. Matthias will then go over some inpatient pain management principles applying to adults, and Amber will then present on pediatric inpatient pain management principles. And we hope to close things out with Q&A for those who are participating live with us. So in terms of our objectives for this workshop, hopefully by the end of our next 45 minutes together, you'll understand the why or the rationale behind why we're making changes to indications for inpatient pain medication orders, in particular the PRN or as needed orders. You hopefully will be able to know how to access and use the adult and pediatric pain order panels and APEX, define the principles of inpatient multimodal pain management, and importantly, apply those principles to the management of adult and pediatric patients. So a bit in terms of the why are we moving from the current state to a new future state very shortly? The goals of our pain orders subcommittee, which really started convening about 3 years ago, were fourfold. The first was to improve multimodal management of patient pain. And for those of you who are less familiar with what we mean by multimodal management, Matthias and Amber will cover that in depth. We also wanted to ensure that we are improving the quality and safety for our patients by decreasing opioid use when appropriate, and importantly, improving the safety of opioid orders when they were necessary in the inpatient setting. And last but not least, we do have regulatory concerns as well. And the Joint Commission, several years in a row, has had findings with regards to our pain medications orders and administration of pain medications. And we wanted to ensure that we were improving compliance with regulatory standards as well. So for those of you who are in the practice of ordering pain medications in the adult and pediatric hospital, you are aware that currently we order as needed pain medications on a mild, moderate, or severe pain scale, with mild pain being a pain scale of 1 to 3, moderate being 4 to 6, and severe being 7 to 10. So what are the reasons to moving to the future state? The first is that the 0 to 10 pain scale, although it is a relatively patient-reported objective scale of their pain, it doesn't necessarily reflect the true spectrum of what the impact of the patient's pain is on their functional goals. In other words, what is actually the impact of their pain on the things they wish to be able to do? So that 0 to 10 scale doesn't really reflect that functional impact. And secondly, as I had mentioned, some of the pitfalls are findings that we've had with the Joint Commission. Some specifics of these findings are patients getting PRN pain meds ordered for severe pain, but there wasn't any pain assessment documented in the chart beforehand, actually showing that the patient was in severe pain. And also we've had issues with no reassessments being in the chart. So the nurse should be going back in and reassessing the patients within 30 minutes to 1 hour, seeing what their response was to the pain medication. And we don't always have those assessments done in the chart. Also, in addition, patients have been given medications for severe pain when it's been documented that they were voicing moderate pain. And then also vice versa, where patients have been given medications ordered for moderate pain when they were documented as actually complaining of severe pain. So this mismatch of what the patient was complaining of or voicing concerns of compared to the mismatch in what was actually ordered for the patient is what led to also these regulatory concerns. So what are we doing about this? You know, a lot of folks, an interprofessional team have been weighing in on this for several years now, and we've also consulted other similar academic institutions in the country. And we're moving forward with a new PRN ordering system where instead of doing it by mild, moderate, and severe pain, we will now be saying this is ordered first line for pain, this is second line for pain, and this is third line for pain. You may recognize that this is somewhat similar and akin to what we order PRN meds for patients with nausea or patients who require a bowel regimen. So in some ways it's similar and aligned with that framework. The two major differences are these pain indications specifically here. We also are adopting a PRN pain indication for breakthrough or emergent pain. And this is defined as acute pain that occurs when the patient has already received their scheduled medication and or their PRN pain medication, and really supersedes any other order that's already ordered for first, second, or third line for pain. So a specific clinical example of this might be a patient arriving perhaps from the PACU to the floor, and between all the bed transfers might be in really, really severe pain. And so this would give the bedside nurse the option to give what is ordered for breakthrough and emergent pain and not necessarily start at what is ordered for first line for pain. We also have a PRN pain medication for procedural pain. So these would be pain medications given prior to an activity known to induce pain. Some examples are provided in the parentheses. And again, we're going to ask the providers to really specify what they mean by procedural pain. I'll give some examples of those screenshots shortly. These changes will impact the adult hospital and both children's hospitals in San Francisco and Oakland, and our go live is Wednesday, March 2nd. So here's a screenshot of our new PRN build, and I'll just highlight here these new PRN medications first line, second line, third line, procedural pain, and breakthrough emergent pain. And again, want to call out, if you're going to order a medication PRN for a procedure, what you will notice is that you won't be able to sign the order because the PRN comment is missing. And we're asking that providers specify specifically what procedure they mean and type that out in the PRN comment field. In terms of where you can find our new pain order panels, you can go to the Orders Navigator, type in pain. For adults, this is what you would see. There's both a not NPO version as well as an NPO version. For PEDS providers, similarly, you'll see something different, except it's ordered as PEDS, both for patients who are not NPO and those who are strict NPO. And just as a comment, only certain services will be able to access the strict NPO pain order panel. And this was done as a discussion, again, through both our medicine and surgical colleagues as to which services typically care for patients who are strict NPO for a period of time. Similarly, you can also find the pain order panels within the adult core admission order set, as well as the pediatric core admission order set. Here is a screenshot of what it looks like embedded within the adult core admission order set. So it's within the core medications orders. And to briefly walk through the pain order panels, this is what you would see at first. You'll have an option of saying, my patient will only have mild intermittent pain during this hospitalization, or they will have more than mild intermittent pain. If you select the first option, what will happen is the panel will open up where you can order either Tylenol or ibuprofen, or you can order both if you want PRN. Or you can select that no pain medication is needed if you do not want to order any PRNs. If, however, you check this second box where your patient will have more than mild intermittent pain, what will open up is the full pain order panel. You'll notice that there are 6 steps. The first 2 are required in order to move forward and sign your orders. The last 4 are all optional. And the first 2 steps that are required are the step to select an acetaminophen approach that's appropriate for your patient. This is the adult screenshot, so 4-gram limit versus 2-gram limit, or for any contraindication, your patient not being able to receive acetaminophen. The second step that is also required is to select a standing NSAID order, and you can select ibuprofen. For those who are briefly unable to take PO, they can do a ketorolac that is linked to an ibuprofen order, or if your patient has one of these contraindications listed above, then you would select my patient cannot receive NSAIDs. The third step would be any additional opioid-sparing medications. What's listed in our pain order panel are lidoderm patches as well as gabapentin. The fourth step is to consider adding oral opioids for pain not managed with the first 3 steps. So in our order panel, this is the oxycodone option, ordered first line PRN for pain, because again, both the acetaminophen and the NSAID that you've selected are around the clock orders. The 5th step is then to consider adding an IV opioid. This would be your second line PRN for pain. In the adult order panel, this defaults to hydromorphone. In the pediatric panel, there are options for both hydromorphone as well as morphine. And then the 6th optional step is to consider if you want to order anything for breakthrough emergent pain and or procedural pain. This step will only allow you to order a total of 2 doses. And the reason why we made this decision was we wanted to make sure the providers were paged or contacted by the bedside nurse if the patient was, for instance, requiring more than 2 doses of breakthrough emergent pain, to then decide, is the currently ordered pain medication sufficient to manage the patient's pain course during the hospitalization. Here's an example of what the NPO pain order panel looks like. It's very similar to the one I just shared, except it does not have the option for oral opioids because your patient is strict NPO. And all the medications listed here are all IV. What I will comment on is for acetaminophen, because of a UCSF health policy, patients can only get 1 dose of IV acetaminophen. If you need more than that, you do need to fill out a non-formulary request, and our orders do link to that non-formulary request if you need more than a one-time order. So I'm going to hand things over now to Matthias to describe a bit more by what we mean by multimodal pain management and to highlight a few other key principles.
Well, thank you so much, Kat. So I will basically talk about three things. First, I give you a little bit of a background on why we're organizing this new order panel that way. What's the idea behind multimodal analgesia? As you heard, it was to a large extent regulatory issues that led to the development of the new order set, but we also wanted to be a tool that helps us to improve pain management. So we're talking a little bit about that. Then I'll give a very short summary about other recommendations, tips about how to do pain management, to optimize pain management. It's super simple, but those are the general guidelines pain management should also always follow. And then I was asked to provide an example. So we're basically going through a case of a patient in need for pain management. And I give an example how good pain management could look like using this new order panel. And I will have to ask you to advance the slides for me. So why multimodal pain management? What is multimodal pain management? That was the slide before. The idea is that we're using multiple modes of analgesia to target different pain pathways. And with this, we're trying to treat pain more effectively, to reduce side effects by reducing small amounts of other medication, and most importantly, to reduce the reliance on opiates by using more non-opiate analgesics. Next slide, please. And this opiate reduction or even opiate avoidance, if it's possible, is key to reduce complications, side effects, and complications in the hospital, but then also subsequently post-discharge. And the next slide shows a little bit what kind of like the worst case scenario is, and there's no automatism, but I would like to create some awareness for the fact that decisions that we make around pain management have consequences in the hospital, but these consequences actually go past the discharge of the patient. So if we, for example, use a lot of opiates because we do not use multimodal analgesia in the hospital, we end up giving more opiates in the hospital. And that has downstream effects, such as more likely the patient will get more opiates when they leave the hospital with their discharge. The more opiates are used in the hospital, the more opiates are being described at discharge, the more refills are being done after discharge, the more likely the patients are to develop chronic opiate use, which doesn't have to, but can subsequently result in opioid use disorder. I definitely don't want to be alarmist. I don't want to overstate our responsibility to, for example, fueling the opioid crisis that we have in this country. It's a way more complex topic, but there is no doubt that a lot of people are exposed to opiates for the first time when they're coming to a hospital, and this has downstream effects. The amount of opiates we're prescribing and what kind of opiates prescribing, for example, has downstream effect. We know that if we write for more than 90 OMEs in the hospital, if we use long-acting opiates for acute pain, if we use a drug like tramadol, patients are more likely to become chronic opiate user. We know that each refill increases the risk for chronic opiate use by 44% after discharge. Independent of whether you had in or outpatient surgery, about 6% of patients who are getting opiates in the hospital or in an outpatient setting will continue to take these opiates and become chronic opiate user. And the majority of patients who are who have an opiate use disorder started with prescription drugs. So there's a certain continuity. And with all these things are certain complications and side effects associated. So if we use a lot of opiates in the hospital, for example, we see more complications such as classic side effects, such as constipation, ileus, nausea, and so on that are problematic, but also the chance for severe adverse events such as respiratory depression. And the same thing happens then subsequently after discharge. So we try to address this issue by reducing opiates as early as possible. Next slide, please. So now the question obviously is, does multimodal pain management really work that well? It was admittedly introduced as a concept before there was really a lot of data supporting it. We know a lot about the individual drugs that we use in multimodal, but how well it really works when we use it together in concert, that was really not that well investigated when we started using it, but now there's more and more data supporting the concept of multimodal. And this is a great example. It's admittedly in the surgical population, but I like this study because it used a larger number of patients. It's 1.5 million patients who underwent either a knee or a hip replacement. And they looked at the effect of the number of multimodal drugs independent of which drugs they were using. And what you see here, next slide, please, is first of all, that there is definitely a trend in pain management to use more and more different drugs, more modalities. So on the left side of the graph, you see both for hip and for knee arthroplasties, the number of modalities used in pain management in the time from 2006 to 2016. And you see, if you would take care of these patients and you would use only opiates for pain management, you would basically be in the lower 5% of excellence. Yeah, that's really no longer the standard of care. Whereas the number of patients who get 2 or more modes of analgesia for this type of procedure has been going up over time. On the right side, you see what the use of multimodal analgesia does on opioid use. And on the y-axis, you see the OMEs that these patients received early after surgery. And represented by different colors, you see here patients who only got opiates, 1 additional drug to opiates, 2 modes of analgesia, and more than 2 modes of analgesia. And you see that the more modalities you're using, the less opiates the patients are using. So it's a really good example about using multiple drugs actually has downstream effects, reduces opioid use. And that's the other part, that also, next slide, please, results in the reduction of other issues associated with opioid use. So for example, if you look at the patients who had a hip replacement, there were fewer respiratory complications, there were fewer GI complications, there were fewer complications such as urinary retention, and it also reduced the length of stay of these patients. Same numbers, basically identical numbers for the knee replacement surgeries. And the authors also pointed out, and this is really important for me to point out too, that the anti-inflammatory drugs, NSAIDs, seem to be the most effective modalities used of all the pharmacological interventions. And I'm emphasizing this because we're definitely underutilizing NSAIDs in general, also here at UCSF, and we would like to promote the use of NSAIDs. Next slide, please. So I can basically skip this. So this resulted in the order set as it was already in more detail explained by Kat, so we don't really have to go through there. But this explains why we're directing people to acetaminophen and a second step to an NSAID, hoping that people actually prescribe an NSAID, then other opiate-sparing adjuncts, and then only can you prescribe an opiate, ideally as a PRN drug, whereas the other drugs are normally scheduled. Next slide, please. So that was the part about multimodal, and I hope I can convince you that it makes sense. And the other key principles that I would love to see uniformly to be followed, and I think then we would potentially dramatically improve pain management throughout the system. One of the things that everybody should do is I try to identify those patients who are at risk for more challenging pain control, and there are definite risk factors, and going in detail through all these risk factors unfortunately would not fit into this this presentation, but I think most of us have a pretty good idea, and there are definitely sources we can direct you to identify these patients. So you can basically come up with a pain management plan that will fit an individual patient early on, rather than seeing your failure and then have to change your practice for pain management. So it's in general fairly easy to identify those patients beforehand who will struggle down the line. Then it's important to continue chronic pain medication the patients came into the hospital with. It says here preoperative, but that also applies obviously to general medicine patients. If a patient is on a long-acting opiate beforehand on other pain medication they're using, please continue it. It shouldn't really happen, but you have no idea how often I see patients who seem to be getting less pain medication in the hospital, sometimes even after surgery than they did take before they came into the hospital. So that should not happen. Never discontinue medication for opioid use disorder. So please do not discontinue buprenorphine and methadone in a patient who has a substance use disorder. When you start opiates, it's always a good idea to go low and slow. If you have a chance to use a non-pharmacological treatment to help with pain management, you should always use this modality. They're normally very inexpensive and very safe, so there's no reason not to use them. Then it's always a good idea to address issues such as anxiety and sleep disturbances. However, it's a little bit of a double-edged sword because very often that results into giving patients other sedating drugs, and that has its own hazards. So that I'm very careful with this recommendation. It's a good idea to proactively address opiate side effects. And if you consider a patient more challenging to manage, if it's a complex patient, please accept help in the management of complex patients. That doesn't necessarily have to be a sales pitch here for the acute pain service. There are a lot of expert providers here at UCSF who can help you with the management of these patients. We have pharmacists on the floor. A lot of providers here at UCSF are very experienced with the management of complex patients. But if everything else fails, contact a pain service. And this very short, I'm not sure how well you are all familiar with this, but there is an inpatient pain report in Apex. I look at it every day when I'm working in the pain service. But in case you do not use it regularly, I would like to briefly introduce you to it because it gives you nice snapshot view of how your patient is doing in terms of pain management. So you find it in Apex under summaries, and then there's a pain header. And then underneath you find several rows of flow sheets that look at that try to assess pain, that try to assess side effects related to pain management and pain itself. So for example, you can see how over time the pain level of a patient that a patient is reporting changes. That's that row, that's Kat right now pointing out. Then on the next slide, you see the rows. This is obviously a more complex patient with a lot of pain medication being administered. And we completely restructured this pain report just a short time ago. And it's now organized into systemic infusions, non-opioid analgesia. So you really want something in those charts in these rows. Then you see what kind of opioid analgesics are being used. And another useful tool for us, it should be useful for you too, is that for each day, the amount of opiate is being expressed, calculated as opiate or oral morphine equivalents. So it allows you to get an idea how much opiate is a patient really requiring to achieve good pain control, and how is this changing over time over the course of their hospital stay. Last slide here. We also have a graphic depiction, and it shows you whether the requirements of the patients, for example, are going up or down. So using this tool, you should have a pretty good idea what you've been using. Are you using non-opiate modalities? And because we're so concerned about sedative drugs, last slide on the pain report is we're also pointing out whether there are any sedative medication, and this includes normally benzodiazepines and muscle relaxants, are being administered. So that's a pain report, gives you a pretty good idea how you're doing with pain management. So then the case example as announced, it's a pretty straightforward case, but it hopefully summarizes everything I talked about here when I try to give an example how to do pain management. So this is a patient, in this case, presenting for surgery. I have to apologize, but those are the patients I mostly take care of, who has chronic pain due to lower back pain, but is otherwise reporting pretty good health, denies any cardiovascular disease or pulmonary disease. The medication before admission, something you always have to ask a patient about when you manage their pain, includes opioids. He's taking OxyContin twice a day, 20 milligram, and then he's taking also Norco 10-325s as needed for pain. And on a normal day, he takes 5 of these pills. So this is definitely an opioid exposed and opioid tolerant patient even. So my question now, based on the new order set and based on the recommendations, is which analgesic drugs would you schedule? Which doses would you choose? And what would be an appropriate PRN pain medication regimen? And I can let you think about it, but unfortunately, I think this is not really a very interactive session here. So I will move to the next slide after you've come up with a plan. So based on what we've discussed so far, or what I've been talking about, we should definitely continue the OxyContin, at least at the dose the patient is taking at home, because there's the expectation that the chronic pain component of their pain doesn't really change. So we want to continue cover that. And then we deal with what we call acute on chronic pain on top of that by giving additional medication. And since we're talking about scheduled analgesics, this patient should have acetaminophen scheduled. The rationale is that this is our standard drug for multimodal analgesia with very few contraindications. Really, the only contraindication for acetaminophen is acute liver failure. Every other patient should get acetaminophen, maybe at a reduced dose if they have liver disease, but pretty much everybody should get it. This is also a good candidate for getting an NSAID. So I would recommend that this patient should get an NSAID such as ibuprofen. Ibuprofen is probably the go-to oral NSAID because it's the best tolerated with the least amount of side effects. And this patient did not display any contraindications to the use of an NSAID. In this patient, I would recommend the use of gabapentin. It is still expected to have an opioid-sparing effect that is especially interesting in someone who already is opioid tolerant, as this patient for sure would be. And this patient is younger. He's younger than 65 years old. If a patient is older, I would normally recommend to either reduce the dose considerably or not even use gabapentin at all. But in a younger patient like this patient, it's probably a good idea to use it. The next question is, what kind of PRN analgesics are we offering? And just as an example, because these are the most commonly used drugs, I used oxycodone and hydromorphone. And with the old order set, you would have probably done a very similar thing at probably similar doses. But what you would probably have done is written for oxycodone against moderate pain and hydromorphone IV for severe pain. We're still using the same drugs at probably the identical or similar doses, but now we use oxycodone as a first-line PRN analgesic drug and hydromorphone IV as a second line. This emphasizes that we're interested in giving the oral drug before we start giving the patient IV medication. And that's a very, very important concept. Fundamentally, we want patients to take oral medication. Oral medication is associated with less side effects than IV medication. It's cheaper, it's easier, it requires less resources, but it's also working better for the patient. It gives them better gradual pain control and has less side effects. I hear all the time that people think that PO oxycodone is more likely to cause nausea than IV medication, and that is just not true. The literature does not support that, and also doesn't make any sense because a lot of this is mediated through our chemoreceptor trigger zone, and that thing is not in the GI tract, that's in our brain. So IV medication are very potent, triggering nausea. Because this patient is opiate tolerant, I would use probably larger doses of oxycodone and hydromorphone as we would use in an opiate naive patient. So here I chose 10 to 20 milligram. This is just an example and needs to be adjusted as you see the patient responding to the medication. And again, oxycodone is kind of like our go-to PO drug. You could use something else such as PO Dilaudid. There's no reason not to do that. I'm always cautioning against the use of tramadol, and we definitely don't want to use any long-acting drugs in opiate naive patients, but this patient is already on a long-acting drug. So oxycodone PO, hydromorphone IV, also on a larger dose. If you want to put some lidoderm patches on somewhere, always a good idea. And that covers that. And now I saw a comment in the chat function, and maybe we'll just take that as Amber is taking over the slide deck. What do you think, Kat?
Sure, go ahead and answer that. And I also see Marilyn Bazinski, who's our clinical nurse specialist for pain, is on. So perhaps Marilyn, you can field this question, how the nurse decides whether to give 10 milligrams or 20 milligrams of oxycodone.
Hi, everybody. Thank you. So I think it's a great question. And I think we're actually guiding the nurses to start low, go slow. So consider the lowest dose in the range. So ideally they would give that 10 milligrams, but we're also having the nurses consider the next PRN analgesics based on a fast-paced algorithm. So what are the patient's functional goals? And Kat, you mentioned that in your presentation. And then thinking about other considerations. Are we worried about their level of sedation? Are we worried about concurrent sedating medication? So evaluating this bigger picture instead of simply going based on a pain intensity scale. So the nurse in this case would probably start with 10 and then reassess after 30 to 60 minutes and determine whether or not it would be appropriate and safe to give that additional 10 before they would give an IV medication.
Thanks, Marilyn. I'm going to hand things over to Amber. And Amber, just so you know, we see your slides in presentation mode. So I don't know if you want to switch it.
Kat, you can still see presentation mode?
Yes.
Okay, hold on. Let me try to change this. Let me try sharing a different way. I picked one way to share. Let's try this now. How about that?
Yep, that's good.
That's good. Okay, thank you. Sorry about that. Still figuring out Zoom. Welcome everybody. I'm Amber Borucki. I'm one of the pediatric pain physicians and was very excited to give this talk today on really the hope was to discuss a lot about multimodal analgesia in pediatric pain management to help support why our pain order set is being changed to reflect the use much more of multimodal analgesia and opioid sparing. So just going to move forward to our outline. So I think my talk in pediatrics mirrors very similarly to Matthias's when he discusses why to consider multimodal analgesia. We're going to go through the same thing, talk about some multimodal analgesia treatments, and then a case presentation as well. So just to start out, just kind of want to discuss the opioid epidemic and some pediatric statistics. So this is just a bunch of headlines that I was very easily able to find and put together about the opioid epidemic and how not only has this affected adults, but this has also led to an effect in pediatrics as well. So some important facts, I like to always discuss some of the statistics. So opioids are the third most common substance in pediatric exposures reported to the Poison Control Center. In children, opioids are the number one most frequent cause of serious injury or death due to unintentional drug poisoning. Between 1997 and 2012, adolescent opioid use rose by 176% and heroin use rose by 161%. Nearly 1 in 4 high school seniors have been found to have a history of lifetime exposure to opioids, including both for medical and non-medical purposes. 8.7% of 12th graders have reported opioid misuse in the year prior in one survey and study. And we know that misuse before the age of 13 years old has led to higher rates of prescription drug misuse later. And one really interesting fact that I was exposed to recently was we just recently had a grand round speaker through our anesthesia department. And the speaker was an anesthesiologist herself who had lost both of her children to opioid use disorder. And she presented about safety with opioids and the use of naloxone. And she had a slide with information and literature about how opioid use disorder, about 90% of the patients that end up having opioid use disorder report the misuse of opioids before the age of 18. And so that's a pretty important fact. We do know, and I think one of the big concerns that a lot of the pediatric physicians have is kind of characterizing any opioid use being a severe concern for later on addiction and overdose, et cetera. What has been found is that appropriate medical usage does not significantly increase the risk. However, when that appropriate medical usage later turns to misuse, that's when there's a concern. And so the big concern is kind of exposure leading to misuse later. So this is just a look at opioid prescriptions in pediatrics. So in 1996, there were about 2.2 million opioid prescriptions versus 62.5 million in adults. And in 2012, there were still about 2.5 million opioid prescriptions versus about 141 million in adults. So what's really been found is that opioid prescriptions in pediatrics haven't necessarily significantly increased from 1996 to 2012 as they did in the adult population. The opioids that were most commonly prescribed were codeine, hydrocodone, and oxycodone. Indeed, we know that codeine is concerning in the pediatric population based upon FDA data that has shown respiratory depression, and also was associated with 26 deaths in pediatric patients after a single dose. However, I do still see codeine being used, even though there's this FDA warning. Trauma, dental visits, and procedures were the most common reason for a pediatric patient to receive an opioid prescription. And also the highest prescription rates were in the Northeast USA, or I'm sorry, had the lowest prescription rates in the Northeast USA. The graph of prescriptions in adults and children, as you can see during the study period of 1996 to 2012, shows the kind of adult prescriptions marching up and exponentially increasing, whereas pediatric prescriptions are staying relatively flat. And since 2012, what's been found is that actually prescriptions in adults have reduced, and pediatric prescriptions have also reduced. However, unfortunately, our opioid overdose continues to increase. So we do know that there's more than just prescriptions that are included that are the cause of kind of overdose related events. Prescription numbers, again, did not significantly increase, but adult family member prescriptions did increase exponentially. And so what was really hypothesized and what really has been found is that pediatric patients may be getting prescriptions from their providers, but one of the, I think about 33% were obtained from a provider. But if you look at the overall patients that did have opioid use disorder, the great number were actually from a family member that a pediatric patient received this from, or from a friend, or from another source. So there's a large portion that are coming from family members, friends, other sources. And I will say from what I've seen in my experience is that often, or that what I've seen is that we've had patients who've come through who maybe had a surgery, they had an opioid prescribed for them, and then unfortunately then began to misuse opioids from another source, which unfortunately we had a patient that had a arm surgery and then began misusing his mother's opioids for a knee surgery. And that's how that was found out. Patients are more likely to get an opioid prescription if they're older age, privately insured, white, non-Hispanic, and the parents have a poor physical or mental health was also tied to that. So then looking at the poison control data around this, there were 188,468 reports of prescription opioid exposures in patients less than 20 years old from 2000 to 2015. The annual number and rate of exposures trended lower after 2009. Again, the most common opioids reported to be exposed to were hydrocodone, oxycodone, and codeine. And if you remember, those were the 3 medications that were most commonly prescribed. The cause for the exposure in the young group, less than 5, were generally unintentional. Most commonly between 0 and 5 years old, the child either got into a bottle or therapeutic error occurred. So mom gave the wrong dose, or dad, or whoever's providing medication, caregiver gave the wrong dose. In the 12-plus-year-old group, 71.5% of those exposures were intentional, and some of those were associated with abuse, misuse, or attempted suicide. Moving forward, this is just a graph showing kind of the averages of exposures through the Poison Control Center, showing you kind of the increased number of exposures at the really young ages, which were unintentional, and then how, again, later exposures increase. The rates of needing admission to a healthcare facility and morbidity were highest in teenagers, and the rates of opioid overdose and suspected suicide did increase by 52.7% during the study period. Hospitalizations rose during the study period as well. They found that the annual incidence rose by 165%, and in particular, very interestingly, in that period of time, methadone overdose also rose, which was interesting. One really important study that did come out in the pediatric world, which has really affected perioperative thoughts, is a study that was done by the University of Michigan. The study came out in December of 2017, and it looked at the University of Michigan was able to get a hold of a lot of insurance data and able to see prescriptions that were being provided to patients after they had surgery. So they looked at about 88,637 adolescents who were opioid naive from ages 13 to 21, who came for 12 really common surgeries like tonsillectomy, hernia repair, cholecystectomy, scoliosis surgery. And what they found was that about 5% of patients continued to receive opioids up to 3 to 6 months after surgery. So for kind of, common surgery like a tonsillectomy, a hernia repair, a gallbladder surgery, patients are still actually getting prescriptions for quite a period of time. And this compared to adults, which showed about a similar finding between 3 and 10% of adults continue to receive an opioid prescription. And this was something I think that the pediatric perioperative and anesthesia community took really seriously and became concerned then about persistent opioid usage after pediatric surgery. So outside of our really severe concerning risks about opioids, other reasons why multimodal analgesia is very supported include your symptoms and quality of life when you're taking an opioid. Nausea is a particular symptom that's unfortunately a side effect, and you do not develop tolerance to when you have an opioid. Constipation can become a very significant issue in our patients, and particularly patients that have any gut surgeries or already have motility issues. This can really worsen things. Pruritus is another symptom. Urinary retention. There can be on longer term use of opioids, hormonal changes. And then there's been a lot of information and studying around mood disorders that are associated with chronic opioid use. Our safety concerns obviously include respiratory depression, sedation, overdose, physical dependence or withdrawal. Not uncommon in our pediatric hospital. We now have worked really closely with our nursing staff. And I see Lena No has joined and helped roll out our withdrawal assessment tool scoring. So we can really carefully monitor our patients after opioid usage to make sure they don't develop withdrawal. And then addiction and opioid use disorder. So I'm just gonna present a slide that the director of our pediatric pain service, Stefan Friedrichsdorf, has shared with me. This is a slide that really goes over for us what multimodal analgesia looks like, which doesn't include just opioids, or doesn't include just medications, but includes also all the non-pharmacological things that we can do. So included kind of different buckets of categories of things that we can provide to a patient that are considered pain therapies. Some you might not think are a pain therapy, but opioids obviously included in here. Then our opioids included in here then are basic analgesics such as Tylenol and our non-steroidal anti-inflammatories. Our adjuvants. So there's a whole list of adjuvants. I have on my next slide, I will go over some of the adjuvants. are really embracing our biopsychosocial model of pain management. So our psychology and family support. So that's our social support. Integrative therapies like mind-body techniques, our regional anesthesia, and our procedural pain treatments, spirituality, so our chaplaincy, and then rehabilitation. So just to give you an idea of what some of each of these look like.
Hi, Amber, I'm so sorry to interrupt you. It's Kat. We're at the hour, it's 1 o'clock. So I'm sorry to cut you short. I just wanted to make sure that we had an opportunity to close things out and see what perhaps questions there are. And maybe what we can do is ensure that we share our wonderful slide decks as well with the GME office, so our learners can have access to all the rich information needed to have an opportunity to present.
Sure, of course. I'm just gonna do a quick through a couple of things. So obviously our adjuvants, which we didn't get a chance to talk about, but our adjuvants are topical medications, and we have a list of those so you can review those. Our integrative options, which we have in our pediatric hospital, psychological treatments, physical therapy, interventional procedures, and then additional psychosocial supports that are embedded in our pediatric hospital. And then I just had a case just kind of discussing how we used all of those different things in a complicated patient case.
Thank you, Amber. All right, so I'm just gonna briefly try to close things out here and share that, again, we'll share all of our slides, but these are the pager numbers for both adult and at least Mission Bay pediatric pain consult services. And I apologize, I did not include Oakland's, but we can update the slides to also include that as well. One other thing I wanted to highlight is Dr. Behrends has really led the way to create this new website that is still under development, but there are a lot of rich modules already up. So if you're interested in learning more about any topic, feel free to go and check it out. It's pain.ucsf.edu. Each module should be no more than a 5-minute read. So it's really quick pearls and tips. So that is it from us.